Good morning, everybody. This is Mrs. Franson, and today we're going to be doing part 2 of Chapter 14. I'm starting on slide 17 of the original lecture, and I'll go all the way to ECT, and then that will be covered in part 3. So right now we are going to talk about okay, I think that we missed a slide. Um, Before we do planning, we want to think about what do we want to achieve for a patient. So we call that outcomes or goals. And so we think about what are we going to achieve for this patient, and it may be the patient becomes more social. It may be the patient expresses their feelings about what they're depressed about 2 or 3 times in a shift, or it may be that they live through the shift if they're very suicidal. And what we want to focus on is the recovery model. And the recovery model emphasizes that healing is possible and attainable for patients with mental illness. We want to focus on the strengths of a patient. We want our treatment goals to be mutually developed. The patient is going to be much more likely to work toward achieving a goal if they're part of setting the goal. And of course, we want all of our goals and outcomes to be very specific to that patient. When we're planning, we want to think about acute and long-term care. We want to gear all of our interventions toward the phase of depression that the patient is in, what their particular symptoms are, and what their personal goals are. Depression can be recurrent and chronic. There's a great table in this chapter 14.2. It correlates symptoms, nursing diagnoses, and nursing outcomes for you. So please take advantage of that great resource. Now, when we're implementing our interventions for patients that are depressed, we want to think about the 3 phases of depression. The acute phase will last from 6 to 12 weeks. During this time, it's highly likely that the patient will be hospitalized. They'll probably start on psychotropic medication, and our goal during this phase is to reduce their depressive symptoms. The continuation phase is 4 to 9 months, and during this time, we're going to be trying to prevent relapse, and many patients will continue on antidepressants during this phase. The maintenance phase is a year or more from diagnosis, and our goal during this time is to prevent future depression. So we may be doing things like cognitive behavioral therapy, helping people to control their thoughts, to change their negative behaviors. We may be teaching them to be more assertive or to have better social skills so they won't be isolated, and they may or may not be on medication. I think that's that misplaced slide that's popping up. Sorry about that. Some of the things that we can do to help our depressed patients is discussed on this slide. We can do counseling and improve their communication, reduce their isolation. We can help them in teaching them to learn about their disorder and how they can be healthier. We want them to direct their own treatment. We want them to make informed consents. We want them to improve their self-care activities. You know, your mother always said, if you look better, you feel better. Well, guess what? That's really true. And we want to help them to get better with teamwork and social interaction, and always think about their safety. Now I'd like to talk to you about the psychopharmacology that we use to treat depression. Now, the first thing I'm going to tell you is some of the general truths about antidepressants that are true for all the classes of antidepressants. Why do we give them? We give them because they benefit 80% of our patients. All antidepressants are going to increase serotonin, norepinephrine, and dopamine. And we know from research that people who are depressed have low levels of these particular neurotransmitters in the brain. The best approach has been shown to use a combination of therapy and psychotropic medication. Antidepressants can improve the symptoms of major depression, but it's not going to happen overnight. Just like the slide shows, it's going to take at least 1 to 3 weeks or longer for the improvement to occur, depending on the medication that you're using. When you're trying out different meds, you need to keep each medication at least a 3-month trial. Now, if you have a patient that is severely depressed, then and severely suicidal, you cannot spare the time to start them on psychotropic medication. These people who are actively homicidal or suicidal are going to need to be started on electroconvulsive therapy as the first line of treatment, and we'll talk about that in lecture part 3. So now let's look at the different classes of psychotropic drugs. The very first class that I would like to talk about is the class that is safest and should be the first line medication for almost all patients, and that is selective serotonin reuptake inhibitors. If you'll remember from the lecture we had on campus day 1, what the name of this class of drug means, that they are inhibiting the cellular reuptake of serotonin, so that more serotonin is present between the synapses in the brain cells. So what we want to do is increase the level. An easy way to think of it is we're increasing the level of circulating serotonin, and that's what we want to achieve. This is a relatively safe class of drugs. It is by far the safest class of antidepressants, so we go to it first. It has the least troublesome side effects of all the different classes. One of the things that we worry about with SSRIs is that they may increase the potential for suicide in some patients. And so this is something you never want to forget about your SSRIs, that some patients will have this response. Now, the thing that patients complain the most about is that it messes up their sexual function. And for some patients, it inhibits the ability to have an orgasm, so patients don't like it and they don't want to take it. But overall, the side effects of the SSRIs are less troublesome than our other classes, which we're going to discuss. Let's look at page 268 and talk about serotonin syndrome. Serotonin syndrome occurs if levels of serotonin become too high, and the symptoms include abdominal pain, diarrhea, sweating, fever, tachycardia, elevated blood pressure, altered mental status, muscle spasms, irritability, and mood changes. Very high temperature is a crisis level indication. That's a big red flag. Now, you as a nurse can make a big difference in whether or not patients develop serotonin syndrome. What you need to do is guard against this event by discontinuing one serotonin enhancing drug before starting a second serotonin enhancing drug. The time period between the two drugs should be 2 to 5 weeks. Let's look at page 266. You will see that the first drugs listed block the reuptake of serotonin. If you look below this, there are subclasses of drugs listed that are blocking the reuptake of other neurotransmitters, and you need to be able to recognize these drugs too. Okay, make sure you review this slide. Make sure you remember this is your first choice for an antidepressant. It's not perfect. It does have side effects, but it has the lowest rate of side effects. Make sure you know the side effects and what are the toxic effects. First of all, serotonin syndrome, which we've already talked about. Any drug can be overdosed. What we like about the SSRIs is if you're going to have to, let's say you're taking care of someone who came into the hospital who's very suicidal and they've been there 6 weeks and now they're going to be discharged. You can not worry as much about an SSRI drug as some of the other antidepressants because they are less lethal if the patient overdoses after they get home. We've already talked about the fact that these drugs are going to increase serotonin, and I want you to know that now we're coming to another type of antidepressant, and we call that the tricyclic antidepressants, or the TCAs. And the way this drug works is it increases both norepinephrine and serotonin. So the circulating levels of norepinephrine and serotonin go up and they make the patient feel better. These drugs have more serious side effects and they're more difficult for the patient to tolerate. Why do we use them? We use them to address individual symptoms. And these drugs are either going to stimulate or they're going to sedate. So based on the symptom of the patient, we are going to choose the drug that does what they need to have done. Because these are more dangerous drugs, we start with a very low dose and we slowly increase. One of the things you need to remember about tricyclic antidepressants is they have anticholinergic effects. So the patient will suffer from dry mouth, blurred vision, tachycardia, constipation, urinary retention, reflux, and weight gain. And none of that sounds fun, does it? One of the things you have to really watch is constipation and urinary retention. If the patient develops these side effects, you must intervene and find a way to help them overcome these side effects. Now, tricyclic antidepressants are not going to take full effect for 4 to 8 weeks. And I'd like to give you some examples of some individualized treatment. If you have a patient that's lethargic and fatigued, then we're going to use the drug norpramin to treat that patient because it is a stimulant drug. If you have a patient that's agitated, you're going to treat that patient with Elavil or Sinequin. These drugs are similar in structure to the antipsychotics, and they also cause postural orthostatic hypotension. So I want you to think for a minute, what group of patients would you not want to take these drugs? And I hope you're thinking about the elderly population because they're already at risk for falling. They don't need sedation, and many of these drugs are sedative. So we try not to prescribe tricyclic antidepressants for the elderly. They also can have toxic cardiac effects, and that's another reason that we don't want to give them to the elderly. So they cause postural hypotension, they can be sedative, and they can cause cardiac problems. They also interact with a long list of medications, which you can look at on page 267, and some of these interactions can be fatal. One of the things we do for patients that are on tricyclics is we want them to take the entire dose at night right before they go to bed, and we're hoping to decrease the potential of effect of the sedation and the postural hypotension by giving it that way. It is contraindicated in some patients. For instance, pregnant women cannot take tricyclic antidepressants. Cardiac patients, patients with glaucoma, or patients with a history of seizure. Now we're going to talk about the most problematic class of drugs that are antidepressants, and that is the MAOIs. So what does MAOI mean? Monoamine just means the neurotransmitters. So what this drug does is it raises the levels of all the neurotransmitters, the circulating levels of these neurotransmitters in the blood, and the main ones are neuroepinephrine, serotonin, and dopamine. Now this is definitely not a first-line treatment. It is only given when all the other drugs don't work. It is effective in some special cases. If you're a person who has an unconventional depression, this may be the only drug that works for you. And there have been patients with PTSD, panic disorder, obsessive compulsive disorder, and bulimia that have done very well on this drug. This is a very difficult drug for the patient to stay on because there's so many dietary and drug limitations when you're taking this drug. Excuse me. You have to control the amount of triamine that the patient takes in when they're on this drug. So make sure that you look at the pages in your book of all the foods and drugs that patients on an MAOI are not allowed to take. One of the big problems with this drug is that there is a potential for hypertensive crisis, and this is the most dangerous side effect of the AMOIs. What are the signs and symptoms of the hypertensive crisis? Obviously, a significant increase in blood pressure to the point that they can have an intracranial hemorrhage. Their temperature goes way up, which we call hyperpyrexia. They can actually begin having seizures, go into a coma, and die. Some of the common drugs that interact with an MAOI are just over-the-counter cold remedies, any medication that increases their blood pressure, and many foods like avocados, smoked meat, cheese, yeast, wine and beer, chocolate, caffeinated beverages. So, first of all, you need a patient that's somewhat compliant to be able to give them this drug, and they have to be closely monitored. Their physician has to know about every medication that they take. They can't take an MAOI within 2 weeks of surgery. We don't give this drug to children under the age of 16. We don't give this drug to anyone with a history of severe headaches. We tell these patients do not go and eat in Chinese restaurants because of some of the additives they put in the food. And it's just difficult for the patient to live with all of the restrictions that they have to put up with. So look at box 14.5 and review this material on MAOIs. Now what about antidepressants in pregnancy? Can we safely give antidepressants to pregnant women? There have certainly been a lot of research done in this area in the last 20 years, and I'm just going to tell you the results in a nutshell of all this research. That yes, antidepressants do increase slightly the rate of preterm birth. There is congenital malformations associated with the use of MAOIs, the tricyclics, and the SSRIs in the first semester. We do know that the SSRIs in the third semester can cause withdrawal in the newborn. So when all the statistics are run, there is a small number of negative outcomes associated with the use of tricyclics, but the result conclusion of most of our research is that antidepressants are relatively safe in pregnancy. Giving drugs to a woman who's pregnant or lactating is always an issue. So what is our role as nurses? Our role is to let the patient make their own decision, but let it be an informed decision. Provide the information to the patient and then support the patient in making the best decision for their individual situation. Having worked with pregnant women for many years, I can tell you that these are very difficult decisions for people to make, and no one takes it more seriously than the expectant mother. Now, is there another side to this argument? Yes, there is, and here it is. Untreated depression is also a risk during pregnancy. Untreated depression increases the potential for preeclampsia, diabetes, hypertension, low birth weight, and premature birth. I like this particular statement and I reflect on it when I'm dealing with women in these circumstances. The severity of the symptoms and the degree to which depression interferes with the ability of the mother to care for herself and her newborn child need to be compared to the risk of taking medication. Another issue we have to talk about is how do we treat children and adolescents who are depressed with psychotropic medication. You may have heard that there is a correlation between the increase in rate of suicide among children and adolescents who take antidepressants. There has been a lot of research in this area too, and we have come a long way from 2005. In 2005, the FDA issued a very strong warning on all antidepressants, stating that the suicidal ideation might increase in children or adolescents taking the antidepressant drugs. So in 2005, the number of prescriptions for children and adolescents decreased, but the number of suicides among this population increased. So the conclusion of many physicians is that the risk of suicide among children and adolescents does decrease if they receive treatment with antidepressants. To minimize the risk of suicide in this high suicide risk population, all patients need close monitoring by family members and the medical community, and very good family education. Now let's reflect again about the older adult. Remember that the older adult does not need to be sedated. They are at greater danger for orthostatic hypotension. So for the older adult, we always want an SSRI as our first choice for a psychotropic drug. For depression, we want to start at half the lowest adult dose. We may increase it very slowly. And we want to remember that tricyclics and MAOIs are much more dangerous for this population because of cardiotoxicity and a greater risk for orthostatic hypotension from the tricyclics. This concludes part 2, and now in just a moment I will record part 3, and hopefully this will help you on your test. Have a great day.